This is a new format of the Global Health Academy. And our first speaker of the GLOHRA Academy series today is Dr. Eva Kantelhardt, who will give a presentation on her research experiences, and her presentation is titled "A Decade of Collaboration to Improve Breast Cancer Care in Ethiopia." Next slide, please. So the Global Health Academy operates under the framework of GLOHRA, which is short for the German Alliance for Global Health Research. And the Global Health Academy has the explicit mission to support the next generation of global health researchers. My name is Esther Efang, and I am the Academy Coordinator of the Global Health Academy. Professor Walter Bruchhausen assigns special responsibility for the Global Health Academy, and myself as the Academy Coordinator. We are based at the University Hospital in Bonn, and we work in joint collaboration with the GLOHRA Secretariat at Charité Universitätsmedizin Berlin. So in the GLOHRA Academy series, we want to focus on research process and point out special attention towards the added value of interdisciplinary and international cooperation in global health research. The speakers will share their opportunities, challenges, and lessons learned on the interdisciplinary and international research projects. Next slide, please. So this is our agenda for the next hour. After my introduction, Dr. Eva Kantelhardt will share her experiences on breast cancer care in Ethiopia with us. Dr. Eva Kantelhardt, she's a member of the GLOHRA Steering Committee and a representative of the GLOHRA Research Area Biomedicine Clinical Research. She is a medical specialist for gynecology and obstetrics, and is a clinical scientist of global oncology at Martin Luther University, Halle-Wittenberg. More than 10 years ago, she started her research on cancer in Ethiopia, and since then she mentored 25 German and 12 Ethiopian PhD students, as well as many Ethiopian and German master students who completed their thesis on cancer. So in the opening ceremony of the Global Health Academy last month, we learned that mentoring is an important issue for early career researchers. So what a perfect match to have you here today, Eva Kantelhardt, on our first GLOHRA Academy series. Next slide, please. Before I hand over to you, Eva Kantelhardt, here are some technical information for the audience. So we are going to record the session and upload the presentation on YouTube, but not the discussion. We decided to do so to keep the discussion as lively as possible. And unfortunately, it is always a challenge to have a discussion with a big group. For now, 70 participants have registered for the seminar today. So therefore, we assigned some people from the audience as panelists, and panelists, they are able to ask questions directly during the question and answer session. So you will receive a notification within the next seconds, or you must have already got it via the chat function, saying that you are assigned as a panelist and that you will be able to ask questions directly in the Q&A session. So to all of you, please leave your microphone unmuted and turn on your video only if you ask a question during the discussion. For those of you who did not receive a message, you will still be able to post questions on the discussion on Mentimeter. So let us just try if the technique is working. For all of you, we have prepared a question for you, and please follow the link in the chat box. And enter the code, and please answer the first question. You have 30 seconds to do so. Okay, the question that we have is, which proportion of breast cancer care patients in sub-Saharan Africa initiate adequate therapy? And I do see that most of you say that you estimate a percentage of 5%, some say 25%, and one person says 27%. Okay, I think Dr. Eva Kantelhardt, she has the right answer to that question. So I'm going to hand over to you, Dr. Kantelhardt. The screen is yours. Please unmute your microphone.
Now, sorry.
Perfect.
Thanks a lot. Thank you very much, Walter Bruchhausen. Thanks, Esther Evang, and thank you to the GLOHRA team for giving me the opportunity to present about the work which we have actually done for quite a while now. About the question, I think, yeah, the answer is going to come while I think I move through our presentation. I'm actually presenting on behalf of a collaboration, the collaboration between Addis Ababa University and Martin Luther University in Halle since about 2010. So it's not really me only. And you can also see that in the question and answer session, there will be colleagues and PhD candidates who are going to join us. When my friend developed breast cancer in Ethiopia in 2008, I thought that this wasn't actually supposed to be a disease in a friend who comes from Ethiopia. People in Ethiopia have infectious diseases, but not breast cancer. During that time, I started to know the then only medical oncologist working at the only oncology center in Addis Ababa, Dr. Bogale. And I realized that Dr. Bogale had a lot of such very rare patients. We started to get in contact and decided we wanted to do some collaboration together. Coming from a German cancer center, I realized that, of course, cancer patient care is really a complex endeavor. You have the population. In Africa, you have, of course, the primary healthcare system. You have tertiary level with few cancer centers, such as the only one there. You have survivorship, you have civil society and socio-cultural norms, living environment. So many issues to consider. We started looking at the university hospital. That's where Dr. Bogale was working, in a small ward with 6 beds and more patients coming. We linked some German MD thesis students and some Ethiopian medical students to jointly sit for around 4 months, collecting data from breast cancer patients who had entered the department between 2005 and 10. Altogether, they managed to retrieve just over 1,000 files. We found that actually the majority of patients, a bit more than half, came from the capital city. And the other half came from the countryside. But knowing that, of course, there are 4 million people in Addis Ababa and nearly 95 million people in the rest of the country, there did indeed seem a need. We found the majority of people, women actually presented quite late. 80% had a positive lymph node status, and the tumors were 5 centimeters on average. When you look at metastasis-free survival, which we were able to determine, after 2 years, about 3/4 of the patients were still without metastases. After 5 years, it was nearly half. These patients had received surgery, chemotherapy, and some form of endocrine treatment. It wasn't too bad, but of course, we know we can do better, knowing that from European or North American perspective, 5-year metastasis-free survival is well over 90%. We had an opportunity actually in 2011. Suddenly, there was interest in non-communicable diseases. There was a high-level meeting of the United Nations on this topic only. And it really put also cancer in the focus of attention. We managed to get a little bit of budget from BMBF, and we started some collaborative research projects. The first thing our Ethiopian colleagues suggested was to look at the population. Why not start a population-based cancer registry? Up to then, there hadn't really been any data on incidence or prevalence from the whole country, which is actually the second most populous country in Africa. So here you can see a very dedicated team. These people manage the cancer registry, which has now been functioning since almost 10 years. We have one secretary, one supervisor, and a data collector who is actually, you can see down here, running around and on a monthly basis collecting new cancer cases from the 20 collaborating institutions. These institutions will always report patients who have a newly diagnosed cancer and who are actually residents from Addis Ababa city. We have ever since submitted our data to the WHO, which presents it on their homepage on Cancer Today, which is the global cancer database. And what you can see here, that from Addis Ababa, we found that from all cancer patients, breast is actually the number one. Cervix is the number two, and giving that 1/3 of cancer is only in women. The rest of the 2/3 shares equally among men and women, which gives a very high, disproportionately high burden to females, I can say. And in fact, our first publication, which we submitted, was rejected because one reviewer said it can't be that 2/3 of cancers are only in women. But if you look at other African countries, this is actually the case. When you look at global data for females, the world is pink. You can see that in the majority of countries, breast cancer is the number one disease, except for those countries where cervical cancer is still there, and breast cancer is becoming more over the years. We also wanted to look at rural population. And just to give you one example, here's with Mr. Wondomu, who in southern Ethiopia did interviews with around 7,500 women within his PhD project. He found 4.3% reporting an actual breast abnormality. All of those women were assessed by a surgeon, and around 50 were found to be eligible for fine needle aspiration cytology. At the end, it was 7 women with breast cancer in that community. When you extrapolate this to the whole of Ethiopia, it would be around 28,000 prevalent breast cancer cases. This fits quite well to the data which we actually collected in Addis Ababa. So to say that there is breast cancer in rural, as expected, but there is also, in urban, but there is also breast cancer in rural Ethiopia. And there is a large number of breast abnormalities who do need diagnostic service. Just to give a brief background about the population and the magnitude. In Ethiopia, it's estimated that there are 16,000 new breast cancer cases. In Germany, 69,000, about 4 times as many. This is, of course, because the population structure is quite different. And I just want to show you that, of course, we are more like a chimney, and Africa, as well as Asia, have more the typical Christmas tree, which means we have much more elderly women. And that means our number of breast cancer cases is high simply due to the age structure. But when we look probably somewhere around 2050, 50 years ahead, of course, we are equally going to change, and Africa will still be the Christmas tree, but there will indeed be more older people. And that means, as you can see here, cancer cases in this world are actually growing, and that's not only in Europe, but also in Africa. And if you can see here, the projection is from 1 to 2 million. This is actually a doubling. And you know that health systems are already strained in that setup. Additionally, there are changing risk factors. Families are becoming smaller, lifestyle is changing, more obesity and so on. So we do expect an increase in breast cancer disease, and we feel that something has to be done about it. Lessons learned. Just to also tell you that there are some things which we have actually gained from data, especially also from collecting population-based data in rural areas. This was our first German MD thesis students, and you can see that you really need a person with knowledge of the local geography, and you need a very important part of the study, and that's the actual team. You need a lot of support letters. That's something which we actually really learned. And you need people to show and to guide you. And I can say that this takes time, but it can grow over the years. One thing I really learned from the first study is that better to listen to colleagues and to think twice if you want to do a rural population-based study in the middle of the rainy season. My MD thesis student actually asked me to pay her for new shoes after that. What we were also able to do was joint activities. Quite early, we managed to visit the African Organization for Research and Treatment in Cancer conference, which was actually in Cairo at that time. We really had a good time, and it was a great team building between our pathologist, oncologist, surgeon, as well as German and Ethiopian students. We presented, we listened, we discussed, and we also had some cultural highlights, jointly sitting on camels for the first times in our lives. Now we additionally moved forward and we said, let's look at the primary healthcare system. Here you can see my surgical colleague from Western Ethiopia actually documented all the patients with breast problems coming from around 500 kilometers to his hospital here. We had this German MD thesis student who actually collected all the files, who managed to find 97% of patients. And just to say that he really made some friends, even in very rural Ethiopia. This was the summer of the World Cup where Germany kind of made a success. We found that breast cancer survival in rural areas of Ethiopia was really not good. Those patients were all operated, but they didn't receive any systemic therapy. Of course, this is kind of logic, but the majority of them, not only to say almost all, were deceased after 5 years. We looked at the care available in the 7 hospitals surrounding that area, and we found surgery was there, and there was some little bit form of palliative therapy, but that was about it. So we said, let's look at the patient. Let's look at the actual breast cancer. And nowadays there are guidelines, and it is highly recommended to personalize, to look into details, into risk and prognostic factors, to look into the tumor biology. Not everybody needs aggressive chemotherapy. We also have targeted therapy, but there is also endocrine treatment, which is a quite cheap tablet. Would this possibly be an option for effective, affordable, and easy treatment? It's only $7 per month. You have to take it for 5 years. It has very few side effects, and it can increase survival by 10% when you take it for 5 years. This is nearly the magnitude, or could be around the magnitude of giving a highly toxic chemotherapy. But in that time, everybody said breast cancer in Africa is estrogen receptor negative. No need for thinking about tamoxifen. Tumor biology is definitely different there. But there were people saying, maybe it's not the tumor biology, maybe it's the quality of those samples. Maybe immunohistochemistry is not sufficient. That's how you usually test those samples to see if there are these estrogen receptors actually on the tumor and whether the patient would be eligible for this tamoxifen. A systematic review came out, and we found that studies reported quite different proportions of estrogen receptor positive disease among their consecutive cohorts. It was between 10 and 90%. The review found that higher grading, larger tumor size, and a retrospective sample collection actually led to lower proportion of estrogen receptor positive cases. And the region of West Africa showed by far less patients with estrogen receptor positive disease than East and Southern Africa. So we thought maybe in Ethiopia, this could be an option. So that's how we started to work together with pathology and laboratory colleagues. This is really a large step forward. Thinking about performing laboratory science in a setting where it's not possible to buy consumables, I think many of you are, of course, much more familiar than I am. We managed to retrieve around 350 samples, and indeed we found 2/3 are estrogen receptor positive, much more than reported earlier from Nigeria. This means it was an opportunity. My very active surgical colleague, now 2014, started the tamoxifen study at his hospital. Now for all patients with breast abnormalities. He did the examination, he did the surgery, and he sent tissue one by one to Germany. We analyzed, and giving a positive result on breast cancer and estrogen receptor status, he actually distributed tamoxifen, which we gave as a donation to those patients. And then 2 years later again, another MD thesis student went out and assessed survival. He interviewed the patients and described adherence to therapy. Would this work in that setting? Here you can see his results. For example, that one patient highlighted here, she had her surgery, she waited quite a while, and then month by month, she came to fetch her tamoxifen. Then there was an interruption, and then she started again. So at the end, we found that out of those patient studies, after 1 year, around half of them still took their tamoxifen. At least it was half, but we found maybe this could be better. There was a variety of reasons, health service or patient side, which led to discontinuation of therapy. Now we have Mr. Sophonias, who actually took up the topic. Mr. Sophonias started his PhD in 2015 and did a cluster randomized trial. 8 hospitals were included. All of them received tamoxifen for free, and half of them received additional breast nurse training. Here you can see the group, and he followed the patients included for now more than 2 years very closely. The intervention team received more information by breast nurses, additional material, and especially they received reminder phone calls, please come fetch your tamoxifen. It's not yet published, but I can say it was quite a successful intervention. Now, having these nice results, we said, why don't we look at a bit larger scale? We had a chance, since we collaborated within the African Cancer Registry Network, a group linking 25 countries where there are actually population-based cancer registries, and we were one of them. We managed to convince 10 centers where actually pathologists had the lead, and all of them were willing to give consecutive paraffin and formalin-fixed paraffin-embedded breast cancer samples to see by a central assessment whether there was a difference in breast cancer biology across the region, or whether it was rather an issue of handling. We managed, and I want to show you a little bit of data from around 700 samples. They were collected. We did a central immunohistochemistry. One pathologist read them all, and we determined the so-called immunohistochemistry-based biological subtype to see whether this is a disease which would benefit from that endocrine therapy from the daily tablet, or more aggressive disease which certainly needed chemotherapy and wouldn't benefit. We used a second method. We did central RNA extraction and used a bit of a modern technique for RNA expression nanostring analysis, and found out about the nowadays more or less gold standard, the RNA-based biological type. And this is just to show you some preliminary analysis. And we really found that here, if you have the regions East, South, Central, and West, indeed West had significantly less estrogen receptor positive disease by immunohistochemistry, and similarly also by RNA expression analysis. So yes, there seems to be probably a genetic difference which leads to these different kinds of breast tumors. So that means East, South, and Central Africa would definitely benefit from tamoxifen therapy. And here is another background information showing that global oncology service really needs improvement. If you look at the US or Europe, there are usually around 50 pathologists per million population. Ethiopia, we are about the average of African countries, which is 0.6. Similarly, about the oncologists, US, Germany around 40, and Ethiopia somewhere 0.7. Number of radiotherapy machines, also highly needed for oncology care. The red countries don't even have one machine. The other orange have about 0.01 to 0.5 for 1,000 cancer patients. In Ethiopia, in total, still there's only one. So there is a high need for innovative and of course, also more treatment options. We also wanted to look at the complexity of the cancer patient's journey in sub-Saharan Africa, and I think this is my last main topic. We did a study on stage therapy and outcome on population level. This was again within the African Cancer Registry Network, where we have 5 very active MD thesis and PhD students. We managed to convince 12 countries, and all of them agreed to host one of those students. Each went and visited 2 countries. So there they sat and looked at 60 patients, breast cancer patients. They also looked at other entities, but in this case, we managed to collect around 700. And here you can see that the green piece of the pie chart, that's early stage disease, whereas the orange and the red especially is the late stage presentation. So you can see the stage at presentation that's really still quite advanced when you look at the African setting. Here we looked at the completeness of therapy initiation, and this is the answer to the question which Essa actually showed at the beginning. We found that around 25% of those patients actually initiated some kind of adequate anti-cancer therapy. It quite varies between the countries, as you can see on the right. Unfortunately, the black, those are the ones who definitely did not receive therapy. The red ones are metastatic patients where the therapy wouldn't prolong the life. And the yellow, and that's also a real problem, are those who received inadequate treatment, which probably causes side effect, but doesn't cause any prolongation or any improvement in their life. Here you can see our results showing that probably on the right, you can, or the green is the ones who initiated a recommended therapy, whereas the others have kind of half or none. And doing the multivariable analysis, you can see no or inadequate therapy really increases the chances of death. Similarly, stage 3. So kind of downstaging and better therapy, that would be a solution to this survival, which really has room for improvement. But of course, we are well aware that this is a very complicated endeavor. Looking at additional factors, just to give a peek preview, we do have now an Ethiopian PhD colleague, Ms. Abigia, who is also doing a cluster randomized trial with the intervention of psychosocial support for cancer patients. And we are looking at quality of life in those patients. And additionally, we also look at our environment. Here you can see our contribution to the tree planting in Ethiopia in 2019. That's something that we will probably even develop beyond our limitations. And we hope that these small plants are going to grow. I want to have even a bigger picture showing you that there has been just recently a new WHO initiative, the Global Breast Cancer Initiative, where there is the goal to reduce breast cancer deaths globally by early detection, timely diagnosis, and comprehensive management. And I think that we are already in contact, and we will for sure promote more advocacy for giving tamoxifen, as well as, of course, looking at all the other factors together with our colleagues in Ethiopia and in other countries. Together, we have really formed a very interdisciplinary research team, which I think is for sure needed in that topic. We have included a lot of German as well as Ethiopian research fellows. This is the answer to the question, what is a good global health research? And I think you can better ask the team or the German colleagues here. In summary, I think it's about collaboration, joint learning, and understanding. It's all about mixed teams of students, masters, PhD, postdoc, and senior researchers mentored across countries. It always includes capacity building and improving patient care, and it definitely needs and takes time. Thanks to all the collaborating colleagues and centers. And thank you, of course, also about our funding. Yeah, this is my final slide. Thanks.